I always select for the orientation session a small topic to be easy and to be like a good introduction about how our studying for the exam will look like. This TOG article is about peripartum hyponatremia. It means having low sodium in the blood around and during the timing of delivery. This TOG is published in year 2022 and it came few times in the exam since then. From this date, July 2022, okay, there were Jan 23, July 23, Jan 24. So already we have about 3 or 4 questions in the exams about this topic, peripartum hyponatremia. Nobody of us will assess routinely for sodium level during delivery. This is not the recommendation. Only some women will need to be assessed that we need to measure sodium level during and after the timing of delivery. We will see what are the indications. Some physiology about sodium level during pregnancy, delivery, and after delivery. You know that during the pregnancy, there is accumulation of fluid. That's why you will find there is increased edema in the legs because there is more retention of fluid. This retention of fluid is more than the retention of electrolytes. That's why during pregnancy, sodium level will decrease slightly. What is a normal sodium level? Normal sodium level from 135 to 145. There is slight decrease during pregnancy. For example, you will find that the level can decrease to 130. Outside pregnancy, this is a level. So you will find number 130 is considered normal in pregnancy, which is not normal in non-pregnant. In non-pregnant, this is hyponatremia, but we know that from 130, it's accepted. That's why you will find the algorithm in the TOG talking about the management starting from sodium level less than 130, as you will see now. So there is some decrease in sodium level during pregnancy because there is over accumulation of fluid. So at term or in the 3rd trimester, the body will have more 8 liters of fluid than non-pregnant women. Also, osmolarity will be slightly decreased. Osmolarity is achieved by the amount of electrolytes in the blood. So osmolarity will be slightly decreased because sodium slightly decreased. Normal osmolarity 275 to 295. You will find the number more towards 275, still normal. So it will be around 280. So it's not absolute, it's a relative decrease of the osmolarity. So there is slight decrease in the osmolarity, slight decrease in the potassium level, starting from 130 is accepted, and there is accumulation of fluids in the body up to 8 liters in the 3rd trimester. That's why when you calculate the dose of something like the anticoagulant, you cannot depend upon the current body weight. Because current body weight is deceiving, already there is volume overload, retention of fluids. So what we use if we need to give this patient blood thinning medication or anticoagulant, we use the booking body weight. The body weight at the very early in the pregnancy, or even pregnancy, the body weight before pregnancy if the booking body weight is not available. So we don't use a current body weight, we use the booking body weight. What will occur during the delivery, during labor? During labor, there is pain, there is sympathetic stimulation. And this sympathetic stimulation will lead to decreased urine volume during labor. Subhanallah. During labor, okay, the patient will not think of going to the toilet or going to the bathroom. Already there is oliguria. It's physiological. Okay, some oliguria are physiological. There are contractions, stress hormones, sympathetic stimulation. That's why there is oliguria. And once the patient delivers, the opposite will occur. There will be polyuria after delivery. So during labor itself, during contractions, it's infrequent that the patient will ask you that she wants to go to the toilet. But after delivery, there will be frequency, polyuria, during recovery after delivery of the baby. And the timing of delivery also is a very stressful time. Because of these hormones, because of this sympathetic stimulation, it's a stressful time, even stressful to the heart. Any volume, excessive volume overload on the heart during the timing of delivery or after delivery can precipitate heart failure. That's why there is a problem called peripartum cardiomyopathy. So it's one of the risks that volume overload during this time can be hazardous to the body and hazardous to the heart. What can cause peripartum hyponatremia? What are the risk factors? Normally, during pregnancy, sodium level is less than non-pregnant. We have just said outside pregnancy from 135 to 145. In pregnant, from 130 is accepted. So already in pregnancy, sodium level is less than non-pregnant. And let's take this smart point. Sodium level 135 to 145. Let's take these numbers, 35 and 45. We can make multiple things from them. For example, normal pH of the vagina is 3.5 to 4.5. pH of the vagina. pH of the blood, 7.35 to 7.45. Okay? From 35 to 45, this is carbon dioxide level. It's important when you are doing interpretation for EPG or blood gases. This is a normal carbon dioxide level from 35 to 45. Okay, these are some examples about what number 35 to 45. And as we said, sodium level in non-pregnant from pregnancy from 130 is accepted. Also during labor, there is vomiting, nausea, stress leading to fluid retention, and increased antidiuretic hormone, which will lead to fluid retention. All of this can lead to low sodium level in the blood. Physiological oliguria and antidiuresis. That's why women during contractions, they don't think of going to the bathroom. Prolonged labor, so these risks will be prolonged. Oxytocin, because oxytocin can lead to more fluid retention, which can again decrease sodium level. That's why we don't use glucose or dextrose while giving oxytocin. With oxytocin, you give fluid in the form of whatever ringer or saline. Don't use dextrose with oxytocin, because oxytocin, you know, it's a structure similar to antidiuretic hormone, because both of them are coming from the posterior pituitary gland. So both of them can cause fluid retention. So don't give dextrose with it, because if you give oxytocin with dextrose, you will lead to retention of fluid with low osmolarity. You are causing now hyponatremia. Excessive fluids, in addition to affecting sodium level, it can even precipitate a problem and precipitate electrolyte imbalance. Spinal epidural because of the vasodilatation. Dextrose infusion, which is not allowed actually. Why to give dextrose? You will find in our curriculum, we avoid using dextrose. So intrapartum, don't give it. Nausea and vomiting in pregnancy, don't give it. Okay, very, very limited indications to give dextrose. For example, one of the indications, if you are treating a patient with DKA, diabetic ketoacidosis, you give excessive volume of saline. This is the management. This excessive amount of saline can precipitate hypoglycemia. That's why when dextrose level blood sugar becomes less than 250, you start to give dextrose to avoid hypoglycemia, because hypoglycemia is more dangerous. It can kill the patient much faster than hyperglycemia. So these are the risk factors. From them, we can guess what will be the indications for sodium level monitoring during labor. So you want to check if the patient using oxytocin, whatever induction, augmentation, as long as you will give oxytocin, you need to monitor sodium level. Any patient that you will give her during labor, you will give her large amount of fluids, leading to positive fluid balance. What is the meaning of positive fluid balance? It's the difference between input and output. If the difference 1,500, so there is 1 liter and a half retained inside the body of the patient, we need to check sodium level. She may develop hyponatremia. Patient using dextrose, and if sodium level already it's a level 130 or less, 130 itself it's a borderline or less, so we need to monitor. So if you test it accidentally or for any other indication, you find it's a level 130 or less, we need to monitor its level. This point about positive fluid balance. Positive fluid balance. It reminds us of another point. It's about hysteroscopy. Because in hysteroscopy also you should assess the difference between the input and the output, because there is what's called fluid deficit. Fluid deficit. This fluid deficit is different if you are using glycine or if you are using saline. Can somebody say what is the cutoff level to say fluid deficit in glycine, and what is the cutoff level to say fluid deficit is positive in saline? Can somebody say? In glycine, 1 liter. In saline, 2.5 liters. As you see, we accept fluid deficit in hysteroscopy if you are using saline up to 2.5 liters, while glycine just up to 1 liter. It's clear that glycine is more serious because glycine is hypotonic solution. Hypotonic solution, so more dangerous. Okay, but now we are talking about intrapartum, not in gynecology, just to remind you about the important numbers. What will occur if there is hyponatremia? This will be the clinical picture in the exam, that the patient has headache, anorexia, nausea, lethargy, and apathy. And if becomes severe, disorientation, seizures, depressed reflexes, coma, up to respiratory arrest, and the pulmonary edema. They are very important because in the exam, it will tell you about these clinical manifestations. So now you will think of hyponatremia. You will check if there is any risk factor, like using oxytocin, positive fluid balance 1.5 liter or more, the patient receiving dextrose, which should not be done routinely, or if sodium level is measured and it's 130 or less. What are the causes of hyponatremia in adults? The TOG classifying the reasons into low sodium with normal blood volume, low sodium with decreased blood volume, low sodium with increased blood volume. For example, low sodium and decreased blood volume, like diuretics, mineralocorticoid insufficiency, sodium wasting nephropathy, it's a kidney problem, GIT loss, that there is excessive nausea, vomiting, or excessive diarrhea. Burn, so the body will lose sodium and also will lose plasma and blood fluid. Pancreatitis, trauma, peritonitis. And uh, low sodium with normal blood volume, hypothyroidism, adrenal insufficiency, low solute intake, primary polydipsia. It means drinking much water. Sodium will be low, but blood still normal volumic. Increased blood volume, heart failure, liver failure, nephrotic syndrome, preeclampsia, water intoxication. So the reasons are classified into low sodium with low blood volume, normal blood volume, and increased blood volume. So these are the reasons of hyponatremia. So I want to check sodium level. If you give oxytocin, whatever for induction, augmentation, for postpartum hemorrhage, you will check sodium level. If you give dextrose, if there is positive fluid balance 1.5 liter or more, or if sodium tested, whatever the reason, and we found it's 130 millimole per liter or less. So what we do, you will find the algorithm is classifying the scenario into this one during delivery and this one after delivery. And every scenario dividing sodium level into 130 and less. We said from 130, it's okay. 130 and less. So from 130 to more than 125 to 130. This one, so this one 130 and more, sorry. This one 125, 130, and this one less than 125. So 130 and higher, accepted. That's why its color is green, and yellow color 125 to 130. 125 and less, it's more severe hyponatremia. Already the green one, we consider it normal. We said normal sodium during pregnancy, 130 and more. That's why nothing. Just if she is still in labor, okay, we'll need to test it later to monitor. So no fluid restriction, it's considered normal level. Repeat sodium if there are still risk factors or positive fluid balance. I will minimize it so you can see it better. I think 150 will be okay. Yeah, it's okay. So 130 and more, 130 and more. No action. Just if still during labor, we will need to monitor sodium if there is positive fluid balance or if there are other risk factors. Easy for the green one. In the green one, this sodium level is normal. Okay, but just we will need, if the risk factor is persistent during labor, we will check again sodium level. Easy for the green one? Can you please write on the chat? It's easy or not? The green one, the level is normal, no problem. Just if it's still intrapartum, we will need to monitor later if risk factors are persistent or there is positive fluid balance 1.5 liter or more. So 130 and more, intrapartum, no management, but I may need to test later. After delivery, finished. No anything to be done. Clear? So again, the green arm, no action, whatever during labor or after, just if still during labor and risk factors are present or positive fluid balance 1.5 liter or more, we will need to check sodium later. This is the green arm. The one above during labor, the one below after labor. Okay, let's take the yellow scenario. That's the level 125 to 130. 125, 130. The one above during labor, the one below after delivery. During labor, we will restrict fluid to 80 ml per hour. Repeat sodium again after 4 hours. Inform senior, inform neonatology. So the main lines, restrict fluid to 80 ml per hour and repeat sodium again after 4 hours. After delivery, same level, no fluid restriction, and repeat testing if risk factors are present. So, again, level 125 to 130. During delivery, restrict fluid to 80 ml per hour, repeat sodium after 4 hours. After delivery, no fluid restriction, repeat sodium if risk factors are still persistent, and discuss. Very easy for the yellow arm. Yellow arm, 125 to 130. During labor, restrict fluid, repeat sodium after 4 hours. After delivery, no need for fluid restriction, and repeat if risk factors are persistent. Easy for the yellow arm. Let's go now to the most risky one. In this most risky one, the patient can even become symptomatic. That's the level 125 and less. Can be symptomatic or can be none. What we do? Fluid restriction, 30 milli per hour, because we are afraid of pulmonary edema. So maximum 130, the same after delivery. Restrict fluid, 30 milli per hour. Repeat sodium in 2 hours. Also after delivery, repeat sodium if risk factors are present in the coming 4 hours. If there is Sento, stop it. Stop it. So Sento should be stopped with the red arm. That's the level 125 and less. We have to stop Sento. And we need MDT if persistent symptoms or worsening. So the level of sodium still decreasing more and more. Although I kept the fluids maximum 30 milli per hour, and there is still progressive hyponatremia or persisting severe symptoms. We need CCU involvement, and after MDT, we can give triple concentration saline, 200 milli in 30 minutes. And if any signs of fluid overload, like pulmonary edema, congested neck veins, give diuretic 20 milli. So please don't give the diuretic as routine, only if signs of volume overload. Again, the red arm. The red arm, whatever during delivery or after, we have to restrict the fluids. To how much? 30 milli per hour. 30 milli, 30 milli. Repeat sodium again in 2 hours, in 4 hours. Sento, stop it, stop it. Okay, in both of them, MDT. During labor, if persistent severe symptoms or worsening, hyponatremia, we need CCU, cardiac care, and MDT, so we can give triple saline, 200 milli in 30 minutes, or we need to give 20 milligram furosemide diuretic IV if there are manifestations of fluid overload. Same after delivery, treat as above if symptoms are progressing. So this algorithm classifying the level of sodium, whatever during labor or after delivery, 130 or above, 125, 130, and 125 and less. Now there is a question in your mind. The question is, what about 125 itself? Because it's present here and there. What about 130 itself? It's present here and there. So if you asked about 130 or 125, what we do? We upgrade. We assume it's the worst one. So 125, I will consider it red. 130, I will consider it yellow. So always upgrade for the safety of the patient, upgrade. Okay? Okay. So we are classifying sodium level into 3 levels, 130 and more, 125, 130, and 125 and less. green, yellow, and red pathway. The one which will need CCU, MDT is the one with level 125 and less. No need for fluid restriction in the green pathway. In the yellow pathway, fluid restriction 30 milli, 80 milli per minute if during labor, no fluid restriction if already the patient delivered. The red pathway, fluid restriction 30 milli, whatever intrapartum or postpartum. And in both of them, we have to stop syntocinon. You can give other ecabolics. You can give misoprostol, ergometrin, if no contraindications. And if there are persistent symptoms or worsening hyponatremia, CCU, MDT, so we can give triple saline, or we can give diuretics if there are manifestations of volume overload. So this was everything about this TOG article talking about peripartum hyponatremia. How it can come in the exam? The most common scenario, he will give you a level for sodium, whatever during labor or after delivery, and he will ask how to manage. So we have to classify 130 and more, 125, 130, 125 and less, green, yellow, and red. And you have to think, is it during labor or after delivery? Any question here? Easy? It's okay. Let's take an example for the questions. So we can help our visual or photo memory. We need to classify. First scenario, green, yellow, or red? What do you think? Number one, the patient in labor. In all the scenarios, it's an EMQ. 133, green or yellow or red? Green, excellent. 128, green or yellow or red? Yellow, perfect. 123, in the group 125 and less, so it's red. 118, it's also red. Okay, so without looking at options, the patient now in labor, and this is the green pathway. What we do? No fluid restriction, and the risk factors are still persistent. We can repeat testing again. That's it. In the yellow one, what we do? We do fluid restriction to 80 milli per hour. What about the red pathway? Fluid restriction to 30 milli per hour, and oxytocin should be stopped. And if worsening or severe symptoms, we need MDT, so we can give triple saline because it will elevate sodium level. Plus or minus giving furosemide 20 milli IV if there are manifestations of volume overload. Okay, so for example, question number one, we need to say that no treatment, but just repeat testing again of sodium if risk factors are persistent. Restrict, stop, continue, give saline, diuretic, restrict, diuretics. Which one here is the best? Routine care. Please notice, if there is an option saying repeat assessment if risk factors are persistent, it's going to be the best. And in the exam, sometimes you don't find the best answer you are searching for. So C, sorry. So continue routine care. So continue routine care. Question 2, we need to restrict the fluid to 80 milli per hour. Which one? And notice there is option A and there is option F. Both of them 80 milli. Which one's better? We are in the yellow pathway. Restrict and repeat testing. So, which one? Yes, here. So restrict and repeat testing, F is much better than A. So always when you are making a choice, please confirm that this is the best choice. So F is the answer. Okay. Scenario number 3 and scenario number 4, all of them in the same group, which is the red arm, that we need to restrict the fluid to 30 milli per hour and stop oxytocin. So restrict 80, stop cento, continue routine, saline 3%. We give saline 2.7%. Okay, after fluid restriction, after stopping cento, after MDT if manifestations are severe, which is not the scenario here. Diuretics, if there are manifestations of volume overload, restrict to 80, restrict to 30, diuretics. So which one is my coming step? Restrict the fluid to 30 milli per hour. So G is the best one. Of course, if there is an option saying restrict fluid to 30 and stop cento, it's going to be the best. Okay, so here G is the best one. Talking about sodium is also present in another lecture, which is a lecture about nausea and vomiting in pregnancy. For example, thesis question. It's a single best answer. 25, coming to the hospital with delirium, 2 weeks of vomiting, 8 weeks pregnant now. On examination, dehydrated, confused with paralysis and lateral gaze. Investigation showing. What is your opinion about sodium? Hyponatremia. There is hyponatremia. Potassium level, it's okay. Urea, creat, accepted. ACT, L-phosphatase. Others are normal, and this is the T. CT showing abnormality here in the brainstem. So as long as there is CT, there is abnormality. Hyponatremia, what it can cause in CT in a patient with hyperemesis? It can cause a problem called central pontine myelinolysis. We can summarize it, CPM. CBM, central pontine myelinolysis. What is it? It's like degeneration in the brainstem caused by severe hyponatremia, or if hyponatremia having rapid correction. Rapid correction is bad. So severe hyponatremia and its rapid correction, all of them can cause problems in the brainstem, in the bones mainly. It's called CBM. So what is this? It's CBM. Why? This is the one which can lead to CT changes in the brainstem, in the bones specifically. So this is CBM. That's why sodium level should be monitored in patients with hyperemesis. This is not what the TOG is talking about. This is actually from the Green TOG guideline about nausea and vomiting in pregnancy, but we need to do intercurricular linking between the topics so we can remember these points. So this was a talk about peripartum hyponatremia. Somebody had any question about the talk or anything we said today? Any question? Okay. I assure you that this lecture will be present on YouTube. I think most of you are present on my WhatsApp channel. I will give you now the link so you can join it. I will put it now in the chat. Because in the exam, the question asks about what is the next step. So these are the list of the things that you will do. and similar one at the bottom. So number one, fluid restriction. Fluid restriction. After that, stop oxytocin, if in use. So number one, fluid restriction. Number two, stop oxytocin. So you will use the same order, like what is present in the guideline or in the TOG. Because in the exam, you will find option one, fluid restriction. Option two, repeat sodium after 2 hours. Option three, stop Synto. Option four, MDT. All of them are right. So what we do, the same order by the TOG or by the guideline. Clear? CCU,